How do you sedate a patient appropriately? How do you know what kind of sedation they need? How do you know what kind of monitors they need? How do you know what's safely going to get them through that so that they are not over-sedated, but that they're not underdosed so that they have recall? And how do you do these things without causing respiratory depression or harming the patient? I think that's what we're going to talk about today. We're going to talk about sedation. We're going to talk about different medications that we use, what settings to use them in, how to use them, and how to get patients and everybody safely through a procedure. So anesthesia is dangerous. It is dangerous to the human body. We give you, you can call them, toxic medications, toxic that if they were given in an uncontrolled setting, they could kill a patient. So there is inherent danger with receiving an anesthetic and with having a surgery or a procedure. So, and that's why, we are trained to give these medications in a way that is safe and that gets you through it. So there's different categories of sedation. And what do I mean when I say sedation? Well, so there's different categories of medications. There's sedatives, and sedatives kind of knock you out, or they make you kind of out of it, not knowing what's going on, and they anesthetize you. There's anxiolytics, medications called anxiolytics. Anxiolytic means getting rid of anxiety. So there's medications that help to get rid of pre-operative anxiety. And then there's pain medications, which are generally like opiates, but other medications. So, and that's called analgesia. So there's sedation, there's anxiolysis, and there's analgesia. Those are the three kind of terms that I'll be using throughout. So the first type of sedation is no sedation. Not all procedures have to have sedation or any opiates or any analgesia or any anxiolysis at all. There are many, 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 many procedures that can be done without it. But that doesn't mean the patient doesn't need it. Everything needs to be customized towards the patient. So you need to look at what is the procedure. So when you're approaching how to sedate a patient, you look at what is this procedure. Are they getting a cataract? Do they have shoulder dislocation? Are they getting a bone marrow biopsy? Are they getting an open heart surgery? Obviously, these are very, very different things. So you look at what procedure are they getting? And then you look at the patient's medical status. Are they healthy? Are they in a healthy state? Did they just walk in off the street? Or have they been in the ICU for 3 weeks? Have they been in the medical ward? Do they have diabetic ketoacidosis? What is their status? And that's something we call the ASA physical status, the American Society of Anesthesiologists, ASA status. And that helps to categorize how sick a patient is. So that goes hugely into consideration. Because just for example, so let's say there's a patient walking off the street, a healthy young woman who walks off the street that is getting an ortho procedure. I can send that patient out to sleep with a big dose of propofol safely. But did you know that propofol is an extremely dangerous medication? It's very, very dangerous. The reason is it drops everybody's blood pressure when you give it to them. It dilates your blood vessels. It's a side effect. It's like an unwanted side effect of propofol. So a healthy young woman, it's not going to, her physiology will be able to compensate for that big dose of propofol that I gave her. No problem. So I know I can give her. In fact, I would give her a lot because a young person often needs more. So I would give that person a lot, 250 milligrams, 300 milligrams, depending on their weight and age. Now, if I gave that, so let's take another patient, a patient in the ICU who's on norepinephrine, epinephrine, and vasopressin, and they're in shock, and they need to come down to the operating room because their bowel is dying and it needs to be resected or it's going to kill them. If I gave that same dose of propofol to that patient, it would probably kill them. So it's all about what is the patient's medical status. This is extremely important as you approach, pre-operative assessment. And then what is the appropriateness? So you look at those things. What is their medical status? You look at their airway, because that also has a lot to do with how you're going to sedate someone. And what I mean by airway is you look at their teeth, you look at their tongue, you have them open up their mouth, you look at the back of their throat, you look at what is their neck circumference. Does it look like they might have a difficult airway? Do they have obstructive sleep apnea, a history of that? Do they use a CPAP at home? So if someone has a straightforward airway, you might lean towards, maybe I don't need to put a breathing tube in for this patient. Maybe I can just lightly sedate them and the surgeon or the proceduralist will give them a little local anesthetic and they'll be fine. So that goes into consideration. And that goes into the next point is what is the appropriateness of the sedation level? Do they need to be deeply sedated? Can they just be moderately sedated? Can they lie motionless in a position for the procedure without being sedated? Are they able to cooperate? Is it someone, do you have a child? that can't cooperate, that can't be redirected? Or do you have someone that has autistic disorder and they're not able to cooperate, but they're otherwise healthy and they're an adult? All of these things are extremely important. And then what are the patient's expectations? What do they want? Are they extremely anxious? Do they take Xanax just to get in an elevator? Like, is that their baseline generalized anxiety disorder? All of these things need to go into consideration when you approach how to sedate a patient. And then when you figure out how you want to sedate them, which we're going to talk about, you want to know how do I need to monitor this patient? Typically, we say, that we do ASA standard monitors. ASA is the American Society for Anesthesiologists. ASA, it's this guideline. So of monitoring someone's vital signs. So that includes pulse oximetry. You put that probe on their finger to see what their oxygen content, or their saturation, I should say, in their blood. A blood pressure cuff to see what their blood pressure is throughout. EKG rhythm, telemetry to see what their heart rhythm and what their heart rate is throughout. And then very, very important is end-tidal carbon dioxide. Monitoring every single breath that they're breathing back at you is carbon dioxide. Because if someone is breathing back carbon dioxide to you, you know that they're breathing. There's a difference between oxygenation and ventilation. These are two different things. Oxygenation is oxygen getting through the lungs and getting into the bloodstream. Ventilation is, are they able to eliminate carbon dioxide in and out of their lungs? And if you're not monitoring someone's carbon dioxide, they actually could be going south really quick, even if their oxygen saturation is fine. These are two very different things. So there are different categories of how deeply someone is sedated. The first category of sedation is none, zero, no sedation whatsoever. Not every procedure needs a sedative or a pain medication. There's many, many, many procedures that don't need these things. And oftentimes that is the surgeon's judgment call, the proceduralist judgment call, like, I can do this in my clinic. So if it's not very painful, or it can be controlled with local anesthetic, and it's also not dangerous to have them not sedated. Someone doesn't have to have sedation. Someone can choose to not have an anesthesiologist, depending on the case, and I get a little more into that. So there's no sedation. The next one up from that we call it nurse sedation, where a sedation nurse that's been trained to give sedatives is the one that is administering the sedatives and monitoring your vitals. In this type of anesthetic, we typically only give opiates and benzos. You definitely do. A sedation nurse does not give propofol and should not give propofol, because propofol can quickly lead to apnea. Someone stopping breathing, and they may need rescue measures to get them back. Now, benzos and opiates together can also cause that as well. But that's why it's kind of lighter sedation. The goal is to keep the patients breathing on their own, and even to be they can be awake, they can be talking during a procedure. An example of this is like a cataract surgery, where an ophthalmologist goes in and they fix your cataract, and I supervise these procedures like this all the time and I never go into the room. I don't have to. I'm supervising a lot of other cases at the time as well. But a nurse is giving benzos, usually like midazolam, and opiates like fentanyl to a patient to get them comfortable. And then the ophthalmologist then numbs up the eye and works. And this works for like 99% of the patients. So that's nurse sedation. The next one we call monitored anesthesia care. We call it a MAC, monitored anesthesia care. This is where you now require an anesthesia provider, whether it's an anesthesiologist in that room or a nurse anesthetist in that room. And monitored anesthesia care it's similar to nurse sedation, but it's just a little deeper. But it's not a general anesthetic. They're not totally under. During monitored anesthesia care, a patient should typically still be able to respond to verbal stimulus. You say, "Hey, how are you doing?" And they say, "I'm doing okay." That's still monitored anesthesia care. But oftentimes we're giving them propofol, and maybe we're going up on our doses, and we have an anesthesia machine right there if we need to convert to a general anesthetic right away. And then deeper from that, the next one from that is a general anesthetic, where someone is they're totally out of it, and typically they have a breathing tube. Technically, a general anesthesia doesn't mean a breathing tube. That's a little too nuanced and too boring to really tease apart. So there's these. I'll just sum it up in these 4 ways of sedating someone: no sedation, nurse sedation, MAC, monitored anesthesia care, and general anesthesia. Now, all of these settings, their vitals should be monitored. I'm going to just take a quick little segue into the Redonda case. Okay, I know I've mentioned a lot on my TikTok and here on the podcast a couple times. So Redonda was a nurse in Virginia who accidentally gave a paralytic medication over midazolam to a patient that was going to get a scan. And that paralytic dose, the patient was given that dose, and the patient went into the scanner, and they suffered brain injury, probably from not being able to breathe because they were paralyzed. That patient was not monitored. And this is the whole crux of this thing for me is that patient wasn't monitored, meaning their vitals weren't monitored. The patient didn't have a pulse ox going on. Anytime someone is going to get a benzo, which was the plan with this patient, they should be monitored. If that patient had been monitored, the patient very, very likely would not have died. Why? Because it would have been detected that the patient's oxygen saturation was going down, 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 down. They would have pulled the patient out and resuscitated the patient right away and gotten the patient back if they had suffered respiratory cardiac arrest. So patients need to be monitored. And so for that reason, Redonda I don't believe that she should be criminalized. That shouldn't have been even brought to court because she was not fully responsible for that patient's death. The system was ultimately responsible. She made an egregious error. That was a big, big problem. And I think she had her license revoked, which that's debatable. I do agree with that. That's fine. But to criminalize her for doing that and to put the responsibility only on her is absurd, in my opinion. Fortunately, the judge who sentenced her clearly understood the circumstances and gave her 3 years probation and no jail time. So, which I was very happy about. Anyway, let's go. I digress back from that. So patients need to be monitored. I mean, you need to monitor patients with what I said before, ASA standard monitors. Remember, that's pulse ox, a blood pressure cuff, telemetry, and end-tidal carbon dioxide. So those monitors need to be in place if you're going to do this. So let's talk about a couple different procedures. Let's start with, we talked about cataract, right? So someone who gets a cataract, that can be done under nurse sedation. You give them 1 or 2 of midazolam, 50 mics of fentanyl, and that chills them out. That's going to chill out the average person, and they'll be able to get that procedure done well. And that nurse is sitting there, and they can redose appropriately, and that nurse is trained to do that safely. However, someone can come in, and I see this all the time, and they're going to get their cataract taken care of, and they ate like an hour before, which that's an automatic cancel the case. Oh, so by the way, why don't we want you to eat? Well, anytime you get any sort of sedative, you could become too relaxed, your esophagus could relax, and you could aspirate gastric contents into your lungs, which could be extremely dangerous and deadly. So, and it happens all the time. People forget, and that's fine. People forget it. It's fine. But I see it, someone with cataract surgery, they'll come in and they're like, hey, I ate an hour ago. And I'll be like, well, we got to delay your case, 6 to 8 hours or for tomorrow. And sometimes that person will be like, you know what? I don't need sedation. Just take me back there and the surgeon will know my eye. I'll just be wide awake. And you know what we say to that? Okay, great. That's fine. That's fine. So being customizing to what the patient wants. And I think that's a great solution. If the patient is okay with that, okay with having surgery on their eyeball that is numbed up, and they're comfortable with that, they're not going to get anxious, and they don't want the anesthetic, and hey, they won't even have to pay for an anesthetic. So that's great. I say, fantastic, come on back, let's get it done for you. Your ophthalmologist is here waiting. So that's great. And then the next person that maybe they ate an hour before, there is no way they can have that procedure without having sedation. They will have a panic attack on the table, and you can't have that, right? Because what did I say before? You have to assess, is a patient willing to stay still? A patient must stay still if you're operating on their eyeball, right? So everything is just customizable to what's going on with the patient. Let's talk about a different procedure. Let's talk about a bone marrow biopsy. So what is a bone marrow biopsy? So this is someone who, often people need a bone marrow biopsy if they have things like leukemia or myelodysplastic syndrome or multiple myeloma, many blood disorders, blood cancers. So a bone marrow biopsy helps to diagnose those things. And so what's a bone marrow biopsy? It's a giant needle, big needle that goes into the side of your hip. It's like a 5-minute procedure. Big needle goes in your hip and it draws out bone marrow, and then that gets sent off to the lab. It takes 2 seconds. So this is an interesting procedure, right? Number one, you don't have to do this with sedation. A patient can be like, I'm good. I don't need this. However, it's painful. So if you need a bone marrow biopsy, I recommend you go to a place that needs sedation, because I've talked to lots of patients that have had it without, and they're like, I will never do it again, because it's painful. It's a huge needle that goes in. I mean, it's painful. And it aches afterwards. So with this, though, it's really brief, right? This is a brief procedure. It's like 5 minutes. A cataract, it can take 45 minutes, hour and a half. And so you have to think of the half-life of drugs. This is a huge part of practice anesthesia. How long do medications stay in your system? And all anesthetists and anesthesiologists, we know this like the back of our hand. We know exactly how long medications are going to linger in your system. So a benzo and fentanyl, the lingering effects will stay for quite a while. Now, the immediate effect might wear off in an hour or two, but the drug half-life will stay around for quite a bit. So for a bone marrow biopsy, yeah, you could give fentanyl and midazolam. However, it may not sedate that person enough because it's painful. It's a quick, painful, just one-off procedure, and then you're done. Whereas the cataract is like, 45 minutes, as I said. The eye is numb. It's not that painful. It's just kind of anxiety-inducing because someone's working on your eyeball. Whereas the bone marrow biopsy, it's like, it's painful. So just giving some fentanyl and midazolam, it may not sedate them enough, and they may feel the pain. And so it may not even, just some fentanyl and midazolam may not accomplish what you need for that patient. And then you have the lingering effects of fentanyl and midazolam. That patient is staying in the post-operative care unit for maybe too longer, and then they're at home and they can be groggy for a while. So we can give something else. You can just give propofol for this. You can just give a push of propofol, a low-dose push of propofol to a patient like this. Propofol has a very quick on and off. It is metabolized by the liver almost as quickly as it enters the liver. It doesn't recirculate around and around. It's a quick on, quick off, just a few minutes. So literally just giving a patient this like a bolus of propofol, and they're good to go. That's all they need. They wake up and they get out. It's a very nice way of doing things. Same with like a cardioversion. Say someone has atrial fibrillation, and they're stable, and they need a shock to the chest to get them out of that rhythm. This is a stable rhythm. That's very common. It's not an emergency. You're doing it electively. I reach for propofol all the time because what is the procedure? It's a shock to the chest. That's the procedure. And I'm performing the procedure. In this case, I'm sedating the patient and I'm performing the procedure, which is just pushing a button on the defibrillator. But it's a short procedure, right? It's a 1 second procedure. It's a press a button, it shocks their chest. They don't need fentanyl and midazolam. That's going to hang around too long. You just give them a push of propofol. I give them a push. I say, hey, how you doing? They're knocked out. They're still breathing on their own. I don't give them too much that they go apneic and not breathe. And then I shock their chest. They wake up. Hopefully I got them out of the rhythm, not always. And they're good to go. So again, everything is relative. Now let's take something like open heart surgery. Say someone needs a new aortic valve. So a surgeon is going to literally take a saw to their sternum, open up, crack their sternum open, slice into their heart and replace that valve. Obviously, that needs to be a general anesthesia. That person needs to be completely sedated and under with many, many different types of sedatives that make sure that they're under. So, we got the whole spectrum and of different sedatives, when to use them, and under what circumstances, and what types of patients, and what kind of comorbidities they have that dictate what you use. Now let's quickly delve into the different types of medications. Let's just talk more specifically about them, and let's start with benzodiazepines. So benzos are usually for anxiolysis, right? For anxiety. So like Xanax, the pill that you take, that's a alprazolam, that is a benzo. So this is a large family of medications: diazepam, midazolam, lorazepam. There's a whole range here. Now, in the anesthesia world, the IV benzos that we typically use in the United States, at least, are midazolam and lorazepam, also called Versed and Ativan. Versed, those are the generic names. The drug names, the brand names. But I'll try to use the generic names as much as possible. So midazolam, it's a short-acting benzo, and it usually makes you feel a couple drinks deep if we give it to you before an operation. And if patients are anxious, and if that anxiety is getting in the way of their experience and it's getting in the way of their care, I quickly will give them to them. I always give patients the options up front. If everybody wants it, I give it to them without exception. So it has sedative qualities as well. And it also has amnestic qualities, meaning it can give amnesia. It can give anterograde amnesia. So it can make people forget the things that happen after they take it. It does not have analgesic effects, midazolam, benzos. They don't provide pain relief. So that's why I was saying with a bone marrow biopsy, just giving some midazolam is not enough. They're not going to have pain relief. They may not remember the procedure as well, but still, it's not going to take care of their pain. So midazolam and benzos can potentiate the effects of other sedatives and opiates. So they can work synergistically, and it can cause respiratory depression, particularly with opiates or something like propofol. So it must be given with caution and with someone that's experienced. The onset of midazolam is about 1 to 3 minutes. I mean, pretty quick, someone's going to feel pretty good. And the half-life is about 4 hours. Now, the therapeutic effect may wear off after 4 hours, but the half-life of it in the bloodstream is going to be about 4 hours. It's generally dosed like 0.5 milligrams at the low end, 1 milligram, 2 milligrams. I usually don't give more than 2 milligrams at a basic preoperative dose. So it's not used, midazolam is not used, or benzos are not used as a primary sedative for longer cases, because you can't keep repeating the doses, because you can sedate them and their breathing can go down, and then you have other problems. So it's used in conjunction with other things. Benzos have a reversal agent called flumazenil. So if someone gets too sedative, you can give flumazenil as an antidote. It will reverse that. It's a new type of benzo. It's called remimazolam. This was approved by the FDA in 2020. It's a short-acting benzo, intravenous. It can be given as a push or a bolus. It has a unique metabolism. It's a very, very fast recovery because its metabolism is not dependent on the liver like midazolam or Ativan. You give a push of this, and it is metabolized in the bloodstream itself. The bloodstream itself metabolizes it. So it has a very quick offset. It's a similar drug metabolism as remifentanil, if you're familiar with that. It's an ester hydrolysis in the blood. I have not used this medication yet myself. I know I have colleagues and other people that are using it and are having good. They do like it because it's quick. For a quick procedure, you just give it, boom. The patient's sedated. They wake up quick. They go home. Everyone's happy. All right, now let's talk about propofol. Propofol acts fast. It's rapid. So propofol is not a benzo. It's not an opiate. It's its own drug. It works on the GABA receptor. It's its own kind of class of medication. It acts fast. It can be short-acting. It's sedative. It's hypnotic. It does provide some amnesia. And it also has antiemetic properties, meaning antiemetic means it helps with nausea. So if you have a anesthetic that's just giving propofol, your likelihood of getting nauseous is actually really low. Again, propofol does not provide analgesia. It is not a pain medication. It is a sedative. It is widely used in many anesthetics. And as I said before, it can drop people's blood pressure. So, and it definitely makes people stop breathing. So those two reasons make it a very dangerous medication. And if it's not given carefully and thoughtfully, it can kill patients. This can be a deadly medication. In fact, this is the drug that killed Michael Jackson. It was used inappropriately, and he died. And that's because propofol has a narrow therapeutic window. Patients rapidly transition to deeper levels of sedation, and there's no reversal agent for it, which it has a fast offset as well, so it's not the biggest deal in the world. It causes pain on injection in most of the people that get it, and that's because it's emulsified in a lipid. IV lidocaine can help with that we give alongside with it sometimes. Okay, and now moving on to opiates. Opiates are its own, obviously, class of drug, and there's many different types of opiates. Opiates are a part of sedation, and they're used in many different things. Typical IV opiates that we use are fentanyl. Right? They have a fast onset, and they have a pretty fast offset. You typically start with doses of 25 mics, and you can go from there, 50 mics, 100 mics at a time sometimes. The duration of action is usually 30 to 60 minutes, and on the onset, a patient you can see the onset within 60 to 90 seconds. So there's fentanyl that can be used for many different reasons, as I said. And then there's remifentanil, which I mentioned earlier. That's an ultra short-acting opiate. Very fast onset, 60 to 90 seconds. And it has a very quick half-time in the bloodstream, something called a context-sensitive half-time, which, if you know what I'm talking about, I won't go into detail about that. Too boring. But it's only like 8 minutes. So if you have someone on an infusion of remifentanil for hours and hours and hours, you turn that off, and in like 8 minutes, it's out of the patient's system. Whereas other medications like propofol and things, they build up in the tissues and they stay and they linger, and they the fat tissue and muscle tissue acts as a reservoir for those medications. Whereas remifentanil, not. That's why it's a very highly useful medication. You start someone on a remifentanil drip, they're going to be apneic. This is for general anesthesia, right? You're not using remifentanil for like nurse sedation, of course. They're going to be apneic, and it effectively acts as a paralytic. It doesn't technically paralyze the body, but a patient's body is not moving if you have someone on an infusion like this. You usually start at like zero point 0.1 micrograms per kilogram per minute, and you can up titrate from there. There's a lot of different other opiates in anesthesia world that we use. Hydromorphone, which is called Dilaudid, typically we give that for post-op pain. Methadone IV, you can give that up front for very painful operations. Meperidine or Demerol, which is also called, helps with post-op shivering. It can help with some analgesia, not a whole lot. And of course, there's morphine, which is not really used much anymore because it can cause histamine release, it can cause itchiness, it can cause nausea, like our other opiates. All opiates can cause nausea. And there's just better medications. I can't remember the last time I prescribed morphine to anybody. It's not that good of a medication. Okay, then you have ketamine. This produces what we call a dissociative state, and this is accompanied by amnesia. And the good thing about ketamine is it provides analgesia as well with no or minimal respiratory depression. Let me repeat that. Ketamine is a fantastic drug because it provides sedation, amnesia, analgesia without respiratory depression. That is a fantastic profile for an anesthetic. I mean, to review, what do benzos do? Sedation, anxiolysis, but they don't provide analgesia, and they can cause respiratory depression. Opiates, analgesia obviously, respiratory depression, big time, sedation, and they linger around. Propofol, yes, it sedates, respiratory depression, but ketamine it provides amnesia and sedation without respiratory depression, and it's an analgesic. It treats pain as well. So it has a combination of really desirable effects all in one package. It has a rapid onset and a pretty short duration of action. It's like 10 to 20 minutes of the duration of action, and it has a half-life of like 2 to 3 hours. So this is a very effective medication. So like say like a 12-year-old comes in with a dislocated shoulder and it needs to be reduced in the emergency department. You can just give that patient a bolus of ketamine. It knocks them out. They're breathing on their own. They don't need a breathing tube. They're out of it. It's giving them pain control enough that they can do the procedure with an orthopedic surgeon or an emergency department surgeon. I think they can do it sometimes. They reduce the joint, and then it clears, and then they're awake, and then they're ready to go, and they don't actually need surgery. It's an incredibly versatile medication. I use it all the time. It's fantastic. It does have some side effects. It can be unpleasant. Some people don't like the dissociative effects. It can cause hallucinations that can be very unpleasant for people, like bad dreams. It can maybe increase intracranial pressure in patients that have traumatic brain injury. It's generally recommended to avoid it in that. It can also unmask myocardial depression in some patients. I think that's kind of a theoretical thing. I haven't witnessed that myself, but it's a very good medication. Oh, and I forgot to mention, ketamine doesn't drop someone's blood pressure like propofol can. So again, it's a hemodynamically stable medication. It's fantastic. And then you have dexmedetomidine, which is also called Precedex in the United States. This is its own class of medication. It's what we call an alpha-2 agonist. It's a sedative. It provides anxiolysis, and it can provide analgesia. So it's kind of like ketamine. It's kind of a combo package. You can give a bolus dose of this, but it can cause bradycardia, low heart rate, and low blood pressure. So it's generally used as an infusion. It can be used in the ICU. It can be used in the OR. It can be used for moderate anesthesia care sedation, where someone's kind of awake, and talking to you, but you have this going on in the background. So it is a versatile medication that is used a lot. It has a lot of great benefits. Some downsides of it is it has a slower onset of action. You start the infusion, it could take up to 15 minutes before that patient even feels it. And then, as I said, it can cause low heart rate and low blood pressure, and it can kind of linger around for a while, prolonged sedation. All right, and then what's another sedative that we use? Anesthetic gas. We call it volatile anesthetics. So gases that we put through the breathing tube. So if you're getting an anesthetic gas, that's a general anesthesia, right? You're not getting it through moderate anesthesia care, what we call MAC, or nurse sedation, and that's delivered through an anesthetic machine. And there's different types of volatile gases. We usually, in the United States at least, we use sevoflurane, isoflurane, and desflurane. And these medications have different onsets. They all have fast onsets. You start someone on a gas, and it's going to sedate them pretty quick, like under a minute. And then they can linger around because that gas can also, again, store in the muscle tissue and the fat tissue. And if you turn off the anesthetic gas, that leaches back out, goes back into the bloodstream, goes back into the brain, so it can linger around. So we have to, as anesthesia providers, we have to titrate these medications and turn them off at appropriate times to make sure patients wake up in an appropriate time. And then we also have nitrous oxide as an adjunct that we do use as well. It has its uses. It's limited. That's laughing gas, nitrous oxide. Anyway, so that's just kind of a primer of sedatives, when to use them. There's a lot of things that go into the decision, and anesthetists and anesthesiologists are making these decisions all day long, constantly, all day long, right? This is part of our job, assessing what is safe for a patient, get them through whatever the procedure is safely, make sure that they are comfortable, that they don't experience pain, and that they come through the procedure, as healthy as they were when they went in. So it's a big part of our job. It's a big topic. I can do more on this, but I think I'll kind of wrap up that discussion. All right, we're going to switch gears here. I get into kind of my social segment. This is what I do. I reel you in with medical information, and then I indoctrinate you with my my social views. What someone could, you could accuse me of being a demagogue for doing that, right? But I don't think I don't think I'm a demagogue. I don't think I have like call to action, and I don't tell you to just trust in me. I think demagogues, I think demagoguery is like trying to destroy the conventional wisdom or the way of doing things, and then trying to confuse everybody, and then be like, the answer is trust in me. Anyway, okay, whatever. I digress. We're going to do a book discussion here. I'm going to talk about a very important book that I think I read like 2 years ago. It's a very, very good book. And it's about monopolization. So if you listen to my content a lot, I harp on ideology. I think ideology is bad. I think being an acolyte of ideology and being like, oh, this is the way to do things is destructive. I think that's one of the reasons that we're so divided, is because we all stack our identity along with ideologies, and then there's no crosstalk between people anymore, and divisions happen, et cetera, et cetera, et cetera. So I don't like ideology. I don't like partisanship. I don't like allegiance to political parties. I think all of this is bad. We are easily manipulated if we align ourselves with an ideology, like remarkably easily manipulated without even realizing it. So, and I think one thing that actually can unite the United States and Western countries, when we're seeing a shift more towards authoritarian leaning political parties, is breaking up monopolies. The markets are incredibly monopolized, unbelievably monopolized, and corporate power is like a behemoth and is influencing our politics, and the court system thinks that corporations are people and that they should have free that their money, that their enormous money is free speech. So monopolies are a competing form of government. It's basically just constant private power that's concentrating, that gets into the public world, and it's taking over things. So I think being anti-monopoly is a way to unite both political parties, because I think we all hate monopoly power. We all hate it. So the book I'm going to recommend really deals with this, and I highly, highly recommend this book. It's called Goliath, The 100-Year War Between Monopoly Power and Democracy. It's by Matt Stoller. Matt Stoller is a very smart man. I follow him on Twitter, and I read his newsletter often. He's extremely intelligent and very well informed, and has a great take on stuff. So just kind of backing up, discussing this book. This book goes over like a sweeping history from the last 100 years of monopolistic powers that have pitted themselves against the average American person. And it's told through great detail with a lot of accuracy and with like a lot of passion, but with a lot of temperance, Rarely do I read a book that is so thoroughly demonstrates current problems through history, and then from that history provides a roadmap out of the current concentration of power in which we live. Stoller starts this history with a question. I remember this well. He starts the book out. Why would a bunch of well-meaning technocrats in the form of the Obama administration bail out the very banks that caused a financial crisis? Given the chance, why would they decide to do the exact opposite of the New Deal era and double down on the very system that created the crisis? The answer to this question requires delving back 100 years and taking us back to Teddy Roosevelt. Teddy Roosevelt branded himself as anti-monopolistic, but actually oversaw monopoly formation and then presided over it. Wilson, his successor, was actually truly anti-monopolistic. Wilson passed the first laws that benefited the workers, the 8-hour workday, child labor laws. He created the Federal Trade Commission, the FTC, and he passed the Clayton Act, which stopped large mergers from happening. The next in line, Harding, took a totally different approach. While Harding may not have had as direct effect on monopolization, his Secretary of Treasury, Andrew Mellon, sure did. This book goes a lot into Andrew Mellon. He played a big role in monopolization. He was a former private banker who likely bribed Harding for the role of being the Secretary of Treasury. Mellon would go on to serve as Secretary of Treasury for 3 more presidents. Mellon owned enormous monopolies, including ownership in over 70 companies. He owned Alcoa, which was an aluminum company that had 100% of the aluminum market. Mellon was in fact good friends with Mussolini, a man he admired for being anti-communist and who fused together government and business. Where Mussolini used murder and dictatorship for his mergers, Mellon had to actually appeal to voters. Mellon was impeached by Congressman Wright Patman. Patman serves as a key figure in this book. He is lauded by the author as being one of the most anti-monopolistic watchdogs in American history. The Depression happened as the markets collapsed, and then a wave of bank defaults soared through Europe and the United States, which stopped lending and seized funds. Unemployment went from 2% to 25%. FDR won over Hoover in a landslide. A reckoning occurred during this time for the monopolists. The famous Pecora hearings are reviewed here, which were aimed at rooting out the monopolists, including Andrew Mellon, and acted as a referendum on a disaster of a financial system that was imposed. New Deal policies then dramatically decreased the unemployment rate and increased housing in the forms of the HOLC and the FHA, which the HOLC, the Homeowners Loan Corporation, and the FHA, the Federal Housing Act, they had racist policies, a topic for another book, which is The Color of Law by Rothenstein, which is an amazing book. But anyway, the New Deal clearly elevated the economic rights of the average American and created a stable foundation on which the civil rights were then built. With the decentralization of banking and other Keynesian moves, monopoly power was greatly weakened in the New Deal eras. But then changes in the zeitgeist started to occur in the 1960s and really culminated in the 1970s. On the left, you had the emergence of economic technocrats like Galbraith, who preached the countervailing forces method or theory, in which monopolies were perfectly sound because the market will naturally create forces that will oppose monopolies. This was a highly influential idea to baby boomer liberals in particular. And then, of course, on the right, you have the Chicago School of Economics, finding fertile scientific ground, disseminating their neoliberal ideas through the courts and politics in the form of Scalia and Goldwater. The Chicago School fundamentally changed rhetoric and language, redefining freedom as unfettered business. The word monopoly began to refer to union and government control, and that corporations were the protector of this newly branded freedom. A fetishizing of meritocracy occurred on both the left and the right, which helped to create a victimization of businesses. It's no wonder that someone like Milton Friedman could insinuate that a business unable to discriminate based on race was an infringement of freedom. Galbraith and the Chicago School loathed one another, but their philosophies were in sync. Wealth and power needed to be concentrated into educated technocrats. Despite Barry Goldwater's presidential failure, the winds were already changing at this time. The Business Roundtable, with the famous Powell memo, if you're familiar, as a manifesto, the Business Roundtable sought to inject business into politics. Riston created CDs, which formed a parallel banking system, which then held the Fed hostage to do anything because it would induce a bank run. Jimmy Carter was actually going to fire all the air traffic controllers anyway before Reagan famously actually did that, a move that supposedly heralded the return of neoliberalism. Nader was around and close with the philosophies of Patman and Brandeis, but seemed more concerned with consumer protection. The Consumer Good Pricing Act screwed over small businesses and helped predatory pricing, which liberals really bought into. Democracy was beginning to be seen as inefficient by both sides of the political party, and a huge wave of mergers took over in the 1980s. And then the politics of affluence really started to reign during that time. Ronald Reagan put 4 neoliberal judges on the court, including Scalia. Junk bonds changed corporate structure. Leveraged buyouts became normalized and completely financialized the system, further concentrating wealth. The opposing Democrats at this time were anti-populist themselves. Bill Clinton won on a populist movement, but with no mention of antitrust. Clinton deeply entrenched more of Reagan's principles. Clinton was a great Republican. He coddled corporate interests and attacked banking restrictions by repealing Glass-Steagall and signing in NAFTA. an agreement that helped corporations find cheaper labor elsewhere. Hillary Clinton sat on the board of Walmart. Clinton appointed pro-monopoly judges Breyer and RBJ, both of whom signed a Scalia opinion that posited that the possession of monopolization was not illegal and it produced economic growth. Section 230, famously, the internet oversight occurred in the 90s, opened up a wave of tech giants to take control, which has huge consequences today. And then Bush Jr. did even less than Clinton about monopoly power, ushering in more powerful monopolies, basically running a war profiteering outfit full on with contractors above more subcontractors. Bush and Cheney are basically war profiteers. When the Lehman Brothers filed bankruptcy in 2007, it spurred a bank run. There were $5 to $7 trillion in unpaid mortgages just flapping in the wind. The culture had changed so much that there was no anti-populist outcry from the Democrat Party when Obama bailed out the banks. This is because the Democratic Party has become the corporate technocratic wonk party full of professional elites. Finance has become sacrosanct to all. The Democratic Party is the party of Andrew Mellon, basically. It's no wonder we have the largest tech companies running every part of our lives. In 2016, Google and Facebook took 60% of all online ad revenue in America, which is the largest source of advertising money. Google has 90% of the search and ad market and can track users across 80% of websites. Facebook has 70% of social network trafficking. 2/3 of Americans get their news on social media. Amazon is the epitome of monopolization, operating on the very dominant market that it owns. As a consequence, America is now a news desert. The fallout from the tech monopolization is unspeakable and beyond the scope of what I even want to talk about with this review. What we learn is that the Obama-era bailouts were an attempt to stop New Deal regulations, not to stop a depression. The liberal technocrats had been indoctrinated by liberal corporate thinking of Galbraith, which was copied and pasted once again from Clinton policy. The Democrat Party ceased to be the party of the people around the 1980s with the resounding election of Ronald Reagan. The two parties have become two sides of the same neoliberal coin. When Obama bailed out the banks, there was no established democratic outcry because of the populist movement didn't exist anymore. Neither party can be trusted to put the power back in the hands of the people. And that is what populism actually is. Populism is average people knowing exactly what is good for them. I'm talking about the populism of like the 1890s, not of 2016. Populism is traditionally rejecting the concentration of wealth and power. Populism is decrying plutocracy, oligarchy, monopoly, and the corporate infiltration into governance. Populism is not perfect because average people are not perfect, but it at least wrestles power away from the liberal elite, the corporate elite, and the conservative corporate fascism in which we live. So what should we do? Learn. Don't fall back into elitism and technocracy. Steer clear of corporate fascism. We have created and recreated ourselves many times over, and we must do it again. The question is not if commerce is good. It's who will control the commerce and the power of the country. America is a battle and a struggle for justice, and we choose who wins. We create this world. So this book is called Goliath, The 100-Year War Between Monopoly Power and Democracy by Matt Stoller. If you want to understand more of what I'm talking about, if you want to understand how power works, I highly recommend this book. It's a little long. It's about 600 pages. I think I did the audiobook for it, and it was very good. All right, let's move on to questions. All right, let's move on to answering some questions. These are from TikTok users. This one is from, what's their name? Let me see here. User 638-294-6601. How do you deal with letting a young person know they are going to die? How do you handle those emotions and not let it spill over into your own life? So thanks for this question. It's a good question. So when I tell patients they're going to die, it's a different role than like an outpatient doctor, right? I'm an inpatient critical care doctor, and so I usually get patients that are pretty sick. And often they know that they're sick. Maybe they've had chronic diseases. Maybe they had leukemia, or they've had long-term cancer, and they're kind of approaching the end. So it may not be as big of a shock or surprise to them or the family if I tell them. Now, if you're an outpatient oncologist, you're a cancer doctor, it's a different thing. And it's in my opinion, it's a harder job that they have because they need to prognosticate way far out. And they may have good data, maybe it's not as robust, but they make these estimates like, typically patients live between 3 to 5 years with this or something like that. And the younger a patient is, obviously that's much more difficult to say. For me, if I have a younger patient who has a terminal illness, I tell them that they're gonna die. So how do you deal with that? I don't have any tricks. I just do it. You develop thick skin. You do not internalize these things. And I go home and I don't think about it again. Now, that's not totally true. And I know that can sound callous, but I get these things out of my brain. I get them off my back. When I go home, I cannot deal with the human, mass tragedy that happens to me at work every day and internalize all that stuff. I couldn't do this every day. So I don't know how I don't let it spill over into my own life, but I just cut it off when I leave the door. And honestly, repetition helps. When you do that, after you've done this over and over again, it becomes, again, it sounds callous, but I don't know how else to put it. It becomes routine. Telling someone that they're going to die, it becomes routine. It is a routine part of my job. And I do it without hesitation. I don't need to psych myself up. I don't need to what am I going to say? I used to be like that, early on in my career, but now you just say it. You just state the facts. You're just transparent. You're honest, and offer your simple condolences. You don't need to be all wax philosophical. Just offer your simple condolences, state the facts, and ask if they have any questions, and then give them time. That's how you do it. There's no magic to it. All right, next question is this is on TikTok. This is from @_foreverdanxious_. This person's question is, and this is relevant to our topic today. What is fentanyl versus midazolam meant to do to someone under conscious sedation? Sedatives/pain meds don't seem to work, and I'm sick of raw dogging procedures. LOL. So, for one thing, I love the expression raw dog. I think it's hilarious. So what she said, what they're saying is, this fentanyl midaz combo doesn't cut it for them, and they're sick of being awake and experiencing a procedure. So for this, I don't know what procedure this person had, but for their procedures, it doesn't work for them. So they need to have that conversation with their surgeon beforehand, being like, look, this doesn't work. I need more, and advocate for more. And advocate for, hey, maybe I need an anesthetist there that is able to dose more. So that maybe it didn't work for this person because the sedation nurse wasn't dosing more because they were afraid of respiratory depression or things like that. So kind of relevant for what I was talking about. So if you've had this experience with anesthesia before, I recommend don't just throw up your hands and be like, that's how it is. Advocate for yourself, being like, I don't want to go through this experience again. What are you going to do? What are you going to do to make this better for me? I need to know. What is the plan? All right. Anyway, I think we'll call it a day there. Thanks for listening. If you've made it this far, thanks for listening to this podcast and my ramblings, my echo chamber that I have here. If you have questions, so I will prioritize asking questions to my podcast listeners. So if you're listening to this and you want a question, I will answer it. I will prioritize it over TikTok questions, and I'll answer it from my email. So email icudoctorecmo@gmail, icudoctorecmo@gmail, and be like, hey, I love the podcast. I have a question. And if you do that, you have a high chance that I'm going to answer your question on the podcast. I will prioritize that answering questions then over TikTok. So do that. And then you can follow me on TikTok. It's @ICUDoctor, and I'm on Instagram at ICUDoctor TikTok. Give me suggestions. Let me know what else. Rate and review this podcast and share it with others. Thank you. I'll see you next time.